Thank you all so much. So I know people are probably tired from the end of this wonderful day. We've had such an incredible group of speakers, but hold on to your seats. We have one last keynote speaker here, and we're very excited to have her. I'm honored to introduce Ambassador Deborah Birx. She is our final plenary speaker today. Ambassador Birx is the coordinator of the U.S. government activities to combat HIV and AIDS and the U.S. Special Representative for Global Health Diplomacy. Oh. All right.
You don't want to say all that, Steph.
Okay,
yeah,
well.
It's great.
All right.
Thank you.
There she is.
Thank you. Thank you. Because I really wanted to spend, 60 seconds talking about how important CFARs are. And I think it was one of the most ingenious, innovative, and important things that NIH ever did. Recognizing that moving across institutions was really critical. And it was the thing I regret most about taking the CDC job was they kicked me off of the CFAR reviews, which I did for almost 15 years, because I really believed in that what we now talk about integration and horizontal discussions was so critical for the advances we made. And I think continuing to make these things better, bringing the Young Investigator Awards, bringing developmental CFARs, I just really think it's extraordinary. And I just really want to applaud all of you, because I know that in addition, it's not a lot of money. So I know that means that you're giving a lot of your individual time in making it work, because coordination and collaboration is extraordinarily time intensive, because that's what we do now every day at the State Department, because we coordinate between all the agencies and working on PEPFAR. I should have entitled this Controlling the HIV/AIDS Epidemic, and we could have had that whole discussion about remission and all of that, just like you had with cure, because that's very controversial too. But I really wanted to talk a little bit about the evolving HIV epidemic and how it needs this constant assessment, and how your data needs to be as granular as the data that you work on, so that we really can take things to the next action. We all talk about how great this decline is from this huge red mountain of HIV infection that's East and Southern Africa, and the dramatic decline in incident rates. But this is offset now by what we're going to talk about is this youth bulge, and the fact that we have twice as many 15 to 24-year-olds in Sub-Saharan Africa. And I think you can see that that incident rate going down by 50% can be completely offset by having 100% more 15 to 24-year-olds. And so this is the epidemic that we have today. And I just want to also thank you all for linking together the work that you do for PEPFAR. Often many of you are involved in PEPFAR as partners, and bringing that back to your institutions and having those discussions. It's been a privilege to go around to many universities and speak. And John Bartlett, when I was at Hopkins, said to me, we would like to talk about PEPFAR, big PEPFAR, when we talk about our small contribution. And I was like, well, that makes a lot of sense. So if you go to pepfar.gov, all my slides are up there. So when you give talks and you want to talk about PEPFAR and what you do in relationship to PEPFAR, you can have any of these slides, and they're up online. They're not on as PDFs, they're as true PowerPoints. So you can just, and I don't have a unique font, unlike Dr. Fauci. I do love the fact that he does. But so you can manipulate the slides, do whatever you want with them, but I think just don't hack them and do terrible things. But we really want this to be available to you all, for you all that have classes and that want to talk about the work of PEPFAR, because this is the burden of disease that we have today. And what I don't show here, and because it's white, is Russia. We don't have any programming, and there's very little programming in Russia anymore. They account for 85% of the new infections in Eastern Europe and Central Asia. And yes, Russia and Ukraine together are over 96%. So when we talk about the expanding epidemic in Eastern Europe and Central Asia, it's solely due to one country, and that is Russia. So we have made this tremendous progress in pediatric new infections, and this is the progress over the last 15 years. And this really gets to the story of why integration works. The one health system that was highly functional in Sub-Saharan Africa and in resource-limited settings was a health system built around improving under 5 survival and decreasing maternal mortality. So there were very strong maternal-child health blocks in most resource-limited settings. And so it's not surprising that this was the most successful area of the entire engagement over the last 15 years, and that was decreasing new pediatric infections. But there is no health system if you're 10, or if you're 15, or if you're 20, or if you're 25 and not pregnant, or if you're a male of any age. You only receive acute care in most of the health systems of sub-Saharan Africa and in resource-limited settings. And this is what the consequences of that, because there's no health-seeking wellness behavior that patients can really adapt to when you're talking about either preventing or people thriving on HIV. With that last discussion of finding people early and getting them onto treatment early is really critical. Now, the reason I'm showing you this, I'm sure you all know about the Sustainable Development Goals, but this becomes very powerful for us because every country except for I think 2 signed on to this. And the important piece of this is this includes a gender equity, a reduced inequities, and a peace, justice, and inclusive society. And that's important to us because it means inclusive. So it means that countries have to embrace all of the people who live in that country, independent of their age, race, or sexual orientation. And so countries have signed on to this, yet you have laws that are criminalizing LGBT activity. And so this becomes a place where we can really speak about some of the other issues. So as I mentioned, we have this dramatic increase in the number of adolescent girls and young women in the highest HIV incident country. Now, this is hard to see. But the difference in the axes, that first axis for 1950, that goes to 20 million. The next axis on the right, on your right, goes to 200 million. So in 1950, we had 25 10 to 24-year-old females, 25 million. We now have 288 million by 2050. But what does this really look like over just the last 30 years of this pandemic? Now, this is a crude way of doing area under the curve when you're on a train and it's moving, and you can't do all the calculations. So I just drew boxes. So the first box from 1990 to 2000 shows the volume in that box. That box is then doubled in size. It's exactly the same size box put on top of the gray box. And you can see by 2020, we have precisely more than 2x the number of 15 to 24-year-olds, both men and women. And this is in sub-Saharan Africa, the dotted line. Sub-Saharan Africa will exceed and has already exceeding China and will exceed India in this age group. 60% of the population by 2020 will be under 20 in sub-Saharan Africa. Now, this coupled with the new data of Slim and Karim that really looked in who's infecting who, because there was all these myths about sugar daddies and 40-year-olds and 15-year-olds and how this all was happening. In reality, it is about 23-year-olds infecting 16-year-olds. Now, some people say to me, oh, that is so amazing. But if you've raised adolescent young girls, you know that they are really excited about dating college students. So it's not unusual for a high school student to date college students. And I always say that to get all the men in the audience extremely nervous about their daughters. But this is what happens. This is not unusual. This is not saying, oh, Africa is different. Africa is similar to many countries where 16 and 17-year-old teenagers think it's incredibly interesting to date 23 and 24-year-old men. And so this is not unusual that this transmission cycle between 24-year-olds and 16-year-olds is ongoing and unrelenting because neither of them know their status. And I'm going to just show a couple of slides on that. So this is where we're headed. So in 2000, we had equal almost big orange down to little orange. That's the pediatric infections, and this is somewhat schematic. So it's based somewhat on data, but it's also a little cartoonized. We also are decreasing the epidemic among over 25-year-olds, but you can see just because of the age, the number of individuals in 15 to 24, that epidemic continues to expand unrelentingly through 2020, and this is what takes us back to 2.5 and a record high of 3 million new infections a year. So the fact that our new infections right now are stable, despite this increased number of young people, means that our incident rates are continuing to drop, but we're headed to a very difficult place with the number of new people aging into that age of sexual debut. So we've kind of organized the program in a fairly simplistic way of how do we find the 25 to 35-year-old young men that don't know they're positive, find them and get them onto treatment and virally suppressed. We launched a huge program, nearly $500 million, called DREAMS, Determined, Resilient, Empowered, AIDS-Free, Mentored, and Safe Young Women. It is strictly a structural intervention at many different layers of structural interventions. We recently added PrEP, but this is the first time that we invested exclusively in a structural program and then added a biomedical. We usually do it the other way. And then working with young men who are not positive and getting them circumcised, talking about condoms, and also making them eligible for PrEP, and to see if this combination of interventions would result in a decrease in the incident rates and the new burden of disease in the under 25. So right now, and this is rising about 3% every year. Last year was 72% of all new infections among adolescents are in women. It's now 75%. That continues to rise. And you know from your own data on microbicide work and vaccine work in young women that that incident rate has basically remained unchanged in the last 10 years. We've also been doing violence against children surveys, and this is where I always ask you all to do something for us. I know that you have behavioral scientists. I know you have groups that work in mental health and other issues. This is the rate of rape of young women across the African countries, Haiti and Cambodia. We have 17 of these now in the field. But you can see it ranges from 15% all the way up to half of the young girls' first sexual experience is rape. And then if you ask over the last 12 months how many have been raped, and you can see it's nearly a third. So it's not just that first sexual experiences were rape, it's that they continue to experience rape within their community. And indeed, in some cases, as just described, this is not a person sometimes foreign to them. This is sometimes their boyfriends that are resulting in their first sexual experience being raped. So this is not an unknown, this is not a community uncle. This is often their chosen boyfriend that results in rape. Now, I just put this up, and I know it's hard to see, and I couldn't get all the actual data so that I could break this down for you in a better way. But very few of these young women ever report their cases of sexual violence. So about a third to 60% do tell someone, but that someone never encourages them or helps them seek services. So only 4 to 10% ever seek services for sexual violence. And then once they do, only 3 to 10% actually get services. So you can see, when you talk about like these clinical care cascades, here's a clinical care cascade for young women that clearly is making it impossible for young women to both bring their perpetrator to justice or get the immediate care that they need. And we know that 1 in 3 girls in resource-limited settings are married by the time they're 18. So these are the solutions we've been working on: DREAMS, Circumcision, and PrEP. I won't go through all of the DREAMS information, but these are the DREAMS countries. These are the highest burden countries in Eastern and Southern Africa, which have the highest incidence of infections in young women. And as I said, it's a structural program. It's really built on empowering young women, keeping them in school, ensuring that they have the right sexual and reproductive health education, ensuring that they have access to post-violent care, but also recognizing how important the family and community is in all of this, and ensuring that we're strengthening the family and the community to actually embrace young women. So part of DREAMS also is really mobilized around this gender-based violence and supporting the normative changes that we have to have. When a third of the young girls' first experience is rape, and that's the same experience their mother and grandmother and aunts have had, it becomes that acceptable community experience, and that it's not unusual then, and so no one thinks of it as unusual and reporting it. So this is the real issue that we've been working on. And joining with a group called Together for Girls to really make it clear that 72 hours matter, and really putting a time around that. The young girls have to get to the clinic within 72 hours in order to get post-exposure prophylaxis. Now here's where we are with circumcision. It's actually in most countries going quite well. The way they worked with this was with traditional tribal circumcision and moved that into a discussion of using that age group and that ceremony to actually do full medical circumcision, to really insert it within the culturally sensitive pieces. So this is working, but I tell you what's working the best is moms just bring their young boys to the clinic and say you're going to get circumcised. So that's been working really well. These are the same moms who got to the ANC clinic and got HIV tested to prevent infection in their babies. They're very interested in their children remaining HIV negative. Now, this is the consequences of some difficulties. So 20 years ago, the immunization rates in Uganda for the EPI immunizations were less than 50%. And now these young boys are at high risk for tetanus. And so last year, we circumcised 1 million young men in Uganda. And because of a new ruling about the fact that you need 2 tetanus shots and then being circumcised 2 weeks later, that means 3 visits to the clinic before you get circumcised. It was tough to get them there once. Getting them there 3 times, not going to happen. So this is really the kinds of issues that we have to deal with in a very tangible way. But I talked about how young men didn't know they were positive. We send out quality assessment teams. Right? We have a large number of teams in country. They go to the clinics and they do this quality assessment of everything that we do. This is just the circumcision profile. And the one place where we really needed referral of HIV positive young men into the clinic is the one place where we have the biggest gap and the biggest red. So this is really allowing us to target resources where the problems are, not where we perceive to be the problems. And so we've really moved to utilizing data in a very granular way to understand what's happening. Now, obviously, you cannot get on treatment to get virally suppressed if you don't know you're positive. Now, last year, we tested 45 million individuals. That's directly testing. We supported testing for another 20 million. But of that 45 million, the prevalence of the positives was about 4%. We only work in the highest burden areas, in the highest burden clinics, in the highest burden regions, or we work with the key populations that are at the highest risk. So to have a 4% prevalence when everything is over 10 in adults is very difficult, and it says we're not really focused correctly. So here, if you look at, this is the DHS Plus survey that was done in Namibia. You can see that the testing of young men, they're in the top, less than 40% know their status, as opposed to 61% of older men and 68% of older women. Now, this is a composite of 3 critical surveys we have in the field, led by ICAP at Columbia, funded by us through the CDC with strong CDC support. This is I'm putting them all together so you can't actually see the numbers because this is part of a World AIDS Day announcement, but I wanted to make sure you could see the idea. If you're under 25, less than 50% of you know your status. But it is quite stunning that if you're over 30, over 80% know their status. And so this is really begins to really tell us where we're doing a great job, where we're not doing a great job. Can you imagine doing a survey in the United States or even in a city and where 80% of the individuals over 30 would know their HIV status? So there are dramatically good elements of the program where we've been successful, but we've been very clear that we have to define where we haven't been so that we can have the biggest impact. Now, this is really a consumer service announcement. Our data now is completely up online by district, age and sex band disaggregated. Male, female, every age band under 25 by 5-year intervals. And then because we really couldn't ask partners to do any more, there's a 25 to 49 and an over 50. Asked for the over 50. Just figured it was important for us to know who was in that older age group. So this is our testing for the first 3 quarters. Analyzed. This just gives you an idea of how many people we have tested. That top line is 25 million individuals tested in outpatient departments, and the triangles show the seroprevalence. But then this is broken down by age band. The line goes across at 2 million. You can start to really see how few individuals under 25 were testing. So it's not only clear from the surveys, but it's also clear from the programmatic data that we're really not reaching young people with the message that they would even consider coming in for testing. And you can see the male testing rates are nearly half what the female testing rates are. So we have this huge challenge of new infections in adults. We have a new and expanding epidemic in under 25-year-olds. And the 25-year-olds don't believe they're at risk for HIV. and they aren't getting tested for HIV. This just gives a stark reminder as how much the epidemic has changed in just 15 years. So in Kenya, we had equal number of pediatric adult infections in 2000, and now it's 90-10. And so this is really, if you were just looking at the top line of 80,000 new infections, you would say we were holding at steady state. But instead, you almost have twice as many new adult infections as you did in 2000 before ART, and this is due to this expanding population. And then if you look at the incident rate curves for pediatrics in the red and adults in the orange, you can see that we really haven't had the progress that we've needed to have. We spent a lot of time working on location, and so this really shows that in Kenya, a whole series of provinces have had remarkable decline in their number of adult new infections, but there's one province where they continue to rise unrelentingly, and this is Nyanza province. This is Kisumu, Homo Bay. This is the Lua tribe area. This is an uncircumcised area that is now 65% circumcised, but still extraordinarily high rates of HIV infection. We have clinical cascades, but you can work on the website. You can download all the data. We have a new tool called Panorama that you can do these comparisons. But the great news is once you get people tested and into the clinic and on treatment, they stay on treatment equally well, whether they're men or women. Now, we're looking at every single age band to see if that's true through every age band. This is Swaziland, a very high burden site, so you can see that they're on their way to achieving what the UNAIDS has described as 90-90-90, including full viral suppression. So we know that the men are missing, and they've been missing from all of our population-based community trials. This is the early data from POPR on the Botswana study, Project Search, which shows that not only were men hard to find, but that bottom line, percent of men enrolled in treatment, 27% of the men, 26% of the men, 32% of the men. So we know from all the early studies that if you don't get viral suppression at the community level in the sexual networks at least above 40%, you don't have an impact on the epidemic. So we have this continued epidemic in men to young women, unrelenting, and men not on treatment. Now, this was what Project Search did. They did this age banding distribution of the number of men who were reached there in the green, and you can see a huge drop-off. If you were between 20 and 30, almost no men were reached for testing. They completely revised how they were doing outreach to men, providing a health clinic focused on their overall health and vitality, of which HIV was the third thing that they talked about rather than the first thing that they talked about, and that seemed to appeal to men. The other piece is really understanding where the issue is by key population. This just compares sex worker populations, where the red is the number of people who are in care of sex workers. Almost all the sex workers have been tested and are in care, but almost none of them are on treatment, even though treatment has been available for them. So we have a different issue in sex workers compared to MSM in South Africa. The reason I'm showing you the South Africa data is because there's not criminalization in South Africa against homosexual behavior. So this is what is really important. They can freely go to the clinics, yet the MSMs, less than 50% of them are ever tested, ever go to the clinic, and of course, never get on treatment then. But if they are tested and they know they're positive, as opposed to the sex workers, they go on treatment immediately. And this is, I think, the same thing with the PrEP in the area, so this is actually quite exciting. So we've also been utilizing our funding to drive these policy changes because we were very excited about the test and start data and the WHO recommendations, but you can see how many countries in sub-Saharan Africa were still at 350 or 500. And just over the last 3 months, we've been really able to push countries into this test and start phase. Reason we think this is so critically important is because it becomes a single public health message. We talked a lot about testing discordant couples, and we just talked about the life cycle of HIV at the community level. So the young pregnant woman would come in. She was probably infected at 16, 17, or 18. So by the time she comes in pregnant at 22, her CD4s were low, and she was started on treatment, or B+, treatment independent of CD4 had already been rolled out. We asked her to bring in her partner. Her partner came in. Of course, his CD4s were higher. And he was turned away and told him he didn't need treatment. Now, the impact of that on adherence is really quite extraordinary. And when you look back now, you go, how could we have said that? Because then it sends the male home to say, why are you staying on treatment why are you taking a day a week or a day a month to stand in line to get your drugs when they told me I didn't need drugs? So now it becomes clear that everybody needs the same thing. It doesn't matter if you're an infant, it doesn't matter if you're 15 or if you're 35 or 65, you should be on treatment immediately. And this is really this new test and start. This is the newest data just coming out of Zimbabwe. We just got this last month, really showing that they've been able to double the number of individuals initiated onto treatment by moving those young men and others that were diagnosed and waiting to get lower CD4 cell counts onto treatment immediately. And we're looking at the impact of that. MSF has been working on alternative service delivery. This is a real question. So those of you who have clinics and if you've done novel things within the United States that you think are rapidly applicable through Sub-Saharan Africa, these are different models at community levels, support groups, adherence groups, community ART, getting people to the place of a yearly clinical visit for wellness and a yearly viral load, and multi-month scripting and ability to get your drugs in the community. And this is same-day start from Croy, Sydney Rosen at Croy, which showed they were very much able to get people started on the same day. They had a 36% increase in the number of clients started on ART, and more importantly, a 25 to 26% improvement on viral load suppression within the first 6 months. So we've been rolling out viral load suppression, viral load as fast as we can. We're behind in every single country. We hope by the end of this year to be at almost 50% viral load access in every country. Some of the countries like Kenya and Uganda are already at nearly 100%, and Rwanda is, of course, at 100%. But I pause here because Rwanda has a health clinic within 2 kilometers of every single community. So it's a different situation than many of the others, but they have well achieved and well on the way to 90, 90, 90. This is their viral load suppression at the community level. Their lowest community suppression is about 66%. So this is really quite extraordinary, but it's a very different country than in many of the countries we work in. We've done the same kind of focusing, using data, granular level, down to the site, looking at prevalence, looking at incidence, looking at new infections, looking at the CD4s and the number of individuals coming into the clinic. And through that methodology, we'll be able to get Zambia and level funding to an 80% coverage. But these numbers hide the fact that that might be 90% for the people over 30 and less than 40% for those under 30. And these are the kinds of issues that we're really struggling with. So finally, I wanted to end with empowering civil society, because another reason why we put all the data up and available to everyone is so that communities and civil societies, no matter where they were in the world, could look at their district and understand who was being reached, where the gaps were, and could help hold us and communities and governments accountable for their health. And I think really the epidemic has taught us from the beginning this intersection of advocacy and scientific advance and the importance of governmental and policy leadership is what will get us to the end. And we believe that civil society needs to be strengthened. We now have quarterly meetings with the entire community to go through the data in every single country so that they become much more data aware and data facile, and the data literacy is going up quite tremendously. And in addition to ensuring that, we are investing directly in the capacity building of civil society organizations, and over just the last 24 months have invested over $250 million in this approach to ensure that the communities. So finally, key populations. We know key populations are extraordinarily high risk. Every single prevalence number here is still way over 10%. But these are the countries that criminalize any kind of MSM behavior. And this is remaining unrelenting, and I think, frankly, is increasing in sub-Saharan Africa. So teams that work on cultural norms, stigma and discrimination within the United States, teams that are working on the social determinants of health, these are the kinds of groups that we really need help with right now. We need your support. We need your insight and understanding of how to really tackle these issues on the continent. Because this is a study we did in Jamaica which shows the healthcare providers themselves are stigmatizing towards their patients. And so these are the healthcare providers who don't want to see people who have HIV. They don't want to see sex workers. And if you're an MSM and HIV positive, you have less than a 20% likelihood to get full care equivalent to a non-HIV positive. So we're also looking at how do we actually quantitate beyond the stigma index. Are there better indicators that we can track and follow, measure, so that we can see if we're changing? Because at the bottom line, we believe that the human rights of all people are absolutely essential to be respected to get to the end of the epidemic. These are the recent headlines from Tanzania, Nigeria, and Uganda, all attempting to tell us that they want to be free of any gay or MSM activity in their country. One of the permanent secretaries to one of these countries told me that homosexuality was an invention of the global north, and they did not have that in the global south. So these are the kinds of issues that we really have to take on, as well as the gender-based violence. We do think we need a more rapid and continuous understanding of the epidemic. I go to many cities in the United States and they say, well, you have better data than we do. Well, we all have to get to better data together, and we have to get it online so that everybody can see progress. But we think that having age and sex disaggregated data in the analytics will help really inform our decision making. So I wanted to leave you with the thought that it is not enough to know where the higher areas of transmission are. It's not enough to know about the hot spots and the locations. It's most important to know where that is occurring in what age group and what population, so that you have the messages, the insights, the ability to reach them from where they are, not to come to you, but figure out how to increase their level of risk and understanding so that they seek out health-seeking behavior, which is quite difficult and we know is going to be complex. And then finally, the issue of protecting human rights and making it central to the HIV response, as it always has been. 37,000 individuals were infected this week, 7,000 young women, 1,000 young women a day. And so these are the statistics that we have, the tools that you have developed that should be taken to full implementation for full impact. But it has to be done in a focused manner, understanding which age groups, what risk groups, and what populations and locations are specifically in need of our services, both prevention and treatment. So thank you very much.
Want to take a couple questions?
Do you have questions?
Yeah. So if we have a couple questions, maybe we have time for just a few questions from the audience. Warner?
Well, that was a great talk. Striking differences in Kenya and Uganda in terms, I think it was incidence rates, new infections, versus most of the rest of sub-Saharan Africa. What's going wrong there? Clearly PEPFAR is investing heavily. Why are those infection rates not going down?
So I'm glad you asked that question. When we first did all the data disaggregation, it was very telling because we had many locations in Kenya where we had a 95% saturation of services. And if you looked in the Nwanza area, less than 30% of the individuals had access to services and any coverage to prevention, to diagnosis, to treatment. And so what it really pointed out to us is whole geographic areas had been left behind because we've been relying on national level data, and that I always call it now the tyranny of averages. It really resulted in us not reaching huge populations at risk. So we moved a significant amount of resources into these areas, whether you're in Zambezi, Mozambique, or the Kisumu area of Kenya.
Yeah, hi, Seth Bloom, MGH and the Reagan Institute. I was wondering to what extent, I may have missed this on a slide, but to what extent PEPFAR has any active programs or at kind of a national level with the education system for testing people in the early to late teen years?
Great question. So there's no health system within the education system. So we're investing this last 6 months, $40 million into ensuring 100% access in Malawi of young girls to school and paying all their school fees. But in exchange, we've asked for the ability to create mobile health centers right outside the schools so young boys and young girls can get clear preventative information and the commodities they need to protect themselves. They can't get condoms, They can't get reproductive health materials. They can't get reproductive health commodities because when they go to the clinic, they're told by the person in the clinic that they shouldn't be having sex and therefore don't need any of those commodities. And so this has been a really difficult situation.
Thank you so much. That was a fantastic talk. Ingrid Katz, Harvard CFAR. I'm really curious what you've been seeing in terms of the changes for this new test and treat strategy in Sub-Saharan Africa. I collaborate with people in South Africa. September, they rolled it out. On the ground, it doesn't look any different. They're still checking CD4s. I think they're kind of not sure how to move forward, and I'm just curious what you've seen from your end.
You know, these are the kinds of studies that you could help us with, because the trouble is when WHO puts out recommendations that say you can still do CD4s, or you can still do a baseline CD4, or you could still do this, countries are reluctant then to stop. And so without the definitive evidence that viral load is enough, countries continue to try to do both, yet we do not have the resources to do both, nor do we have the laboratory technician time. You know, we have a finite number and they need to be doing viral load, not CD4. So this has really become a real difficulty when you try to continue everything else you were doing and then try to do more on top of that. We know that doesn't work. It hasn't worked for us yet in the HIV pandemic. So we're really trying to force that change into these new policies. We usually just stop paying for them. That stops them. That's our next step when we can't get that done. Yes.
Doug Richmond, UC San Diego. So in the light of all of the impact of all these activities, I think it's pretty clear that the budget for PEPFAR at best has been flatlined for quite a few years, and other sources of funding may be diminishing. How are you going to execute these new initiatives that you're talking about with that challenge?
Yeah, that's a great question. We were able to do 3 major new initiatives in the last 2 years despite level funding. One of them was the DREAMS initiative. We also doubled the number of children that are on treatment through our Accelerated Children's Treatment Initiative, and then this new big Key Population Initiative and the Key Population Investment Fund. We did that because of focusing and really ensuring that every dollar was utilized in an effective manner. So once you get to that point, there isn't a lot of other places where you can find money. That's why we're really working with countries now on alternative service delivery, because this model of wellness and yearly clinic visits as a check-in for you doing well, if countries are going to take on hypertension and diabetes and that preventive interventions, they're going to have a model like that. But that is not a model that has been routinely utilized, and it makes everybody quite nervous. So we're really working on that, because that's the only place where the cost savings are to continue to expand these prevention interventions for young people.
I think for the interest of time, we're going to have to stop now, but please join me in thanking Ambassador Burks. And just to finish, we're going to have Bruce say a few closing words.
Yeah, so I think we've all participated in what's been really an extraordinary day, and I want to thank all of you for being part of it. I want to in particular thank Doug and Ingrid, Doug Kwan and Ingrid Katz for being the organizers of what I think has really been a unique opportunity to showcase the emerging investigators. I also want to thank our plenary speakers that bookended the day, Ambassador Burks and Dr. Fauci. I want to thank all of the moderators, the panelists, and in particular the speakers during the day. And then finally, I think this entire day has gone very smoothly, and that's because of the administrative staff we have on our CFAR. So I'm hoping I can get, I know some of them I think are outside, so I'm hoping I can get everybody to participate with me in some hip hip hoorays. I'm going to name each of their names, and then we're going to say hip hip hooray. So Amanda Gorey, hip hip hooray. Bethany Booth, hip hip hooray. Alberto Ottoboni, hip hip hooray. And finally, Mark Ingassiola, who keeps the whole CFAR going. Hip hip hooray. So thanks very much to everybody.